No, it's my pleasure to introduce Dr. Mohammed Hamadi from Imperial College London. Yeah, so Dr. Hamadi.
Quite promising, and they are compared favorably to the results of the open surgery at all measured variables. However, to achieve those good results, there are certain prerequisites that needs to be fulfilled, including the robust setting and pathway, appropriate patient selection, good technical skills, and some durability issues that need to be addressed. I'll touch on a couple of those points. There is a checklist of anatomical suitability, which starts from the axis that needs to be of good diameter, not occluded, and less tortuous as possible. By the way, none of those points is an absolute contraindication, but increase the complexity level of the procedure and then could lead to more complications and comorbidities. The severe angulation at the level of below the level of the renal arteries is a significant anatomical challenge. This is a case of 8 centimeter AAA waiting for CABG, and we enthusiastically decided to go for 3-vessel fenestration. And I managed to cannulate the SMA and the left renal artery, but the right renal artery fenestration opened at 6 o'clock instead of 10 o'clock. And this is a problem of the mismatching between the planning and the behavior of the artery when you put the relatively stiff device and start to deploy it. The downward angulation of the side branch can make the cannulation from the femoral approach quite difficult, especially if it is combined with the angulation of the aorta. This is obviously not a problem with the branch graft, but a problem with the fenestration. Side vessel stenosis can be challenging because it increases the risk of the dissection, and if you dissect the artery and you can't cannulate it, the procedure has failed. The multiplicity of the renal arteries can be a problem because there is some manufacturer limitations of where you can put the fenestration in the Cook device. Early branching of the renal artery or the SMA could lead that when you put the bridging stent, you could cover one of the important branches, and that adds to the limitations of the procedure. Significant or severe narrowing of the aorta at the level of the target vessels can be a contraindication, so you need at least 19 millimeter, but in this case that I'm showing here is a 14.5. Similarly, if the aorta at the level of the target vessel is quite wide, that's also challenging because you don't have 100% control of where the device is going to open. In this case, I managed to cannulate the SMA, but there was no way to cannulate the renal arteries from the femoral approach, and I had to deploy the stent completely and lose any control over orienting the stent and come from the brachial approach and stent the renal fenestration. It's relatively easy, but that's not really ideal. The disease arch can be a problem because especially with the branch cases, because this increases the risk of stroke and distal embolization. Severe angulation of the descending thoracic aorta and tortuosity can be extremely challenging for both cannulation of the branches or advancing the bridging stents. This patient has aneurysm in the thoracic aorta as well as in the abdominal aorta with S-shaped descending. This patient eventually ended up with hybrid repair, and I managed to advance through the conduit of the spaghetti, the stent graft through this S-shaped descending. Dissection is an interesting entity. Despite the interesting reports recently about putting branch stents, but I think those reports should be interpreted with great caution, especially in cases where you have severe maceration of the aorta, as in the case on the left side, or severe narrowing of the true lumen and the flap is thick, chronic dissection, and you don't have 100% confidence about the mobility of the flap when you put the stent graft, and also if you have origin of the side branches from different lumen, false and true. A couple of years ago, we looked retrospectively at 70 cases of thoracoabdominal aortic cases that referred to our center, and we assessed them in terms of suitability for branch and fenestrated stents, and we found 40% of them they have 3 or more adverse anatomical features which make the procedure either extremely difficult or undoable indeed. Then we move to the issue of durability. The bottom line that we are using bridging stents and accessories that are not built for purpose, and they're using peripheral stuff to use to cannulate vessels in the abdominal aorta. This case, the branch to the celiac trunk dislodged 6 months after successful deployment, managed to embolize it, and the patient did well because he already had severe stenosis of the celiac trunk, but again, this is less than ideal situation. Side branch kink is a recognized complication, as in this case, and this particularly concerning when there is long branch or unfavorable angle between the aorta and the side branch. This case was embolized and he had lienorenal bypass. This is an interesting case. It's a fracture of the atrium stent, which is very commonly used in those stents. It was fractured at the fenestration site. It's not common, but it can be seen. The migration of the thoracic component or the body component is another recognized complication, which highlights the importance of the follow-up CT angiograms, and we should interpret and look at those CTs not only for endoleak, but also at the position of the various components. A new generation has come to the market recently, which is the Anaconda Fenestration, and there is another company coming, but I'm not allowed to talk about it now. But the fenestrated Anaconda has certain features which is different from the Cook. You can cannulate from the brachial approach before full deployment of the stent. You have more control over orienting the fenestration. You can cannulate one vessel and reorient the fenestration of the second one. And you can make any sensible number of fenestrations in any location you like in the unsupported segment, which is different from the Cook device. And using this stent, we managed to stent patients with severe side-to-side angulation, patients with AP angulation, patients with severe narrowing at the aorta, the one I showed earlier, and patient with pre-existing stent. This is the 4-fenestration Anaconda cuff, and patients with 2 renal arteries only 6 millimeters apart on the right side. We published our results with those complex anatomy with Anaconda with 6 months follow-up, and that's the point with Anaconda right now, because we don't have long-term results because it's a new one. We did, in collaboration with the biomechanical engineering of the Imperial, a CFD study on 6 Anaconda patients, pre and post stenting. We looked at their CTs and they generate the computational flow dynamics, and we found that the post-stenting, there is much more luminal flow or tubular flow in the stented segment, and small vortices exerted along the fenestration sites, and the overall dragging forces are quite low. So in theory, the migration forces should be low, but we're waiting for the clinical results. Now, future directions can be categorized into 2 things. One is the stent technology itself, and second is the imaging. For the stent technology, there is probably a wish list, and I'm sure we'll be there one day. I'm not sure when, but I'm sure the stent technology is rapidly developing. For the imaging, the rotational angio proved to be useful in certain cases to detect endoleak on the table, and so you can address it early, and also to verify position or the position of the stents or the side vessels in certain difficult anatomies. Image registration and fusion will have, and I hope will have, a significant role in the future. The purpose for using this is to shorten the procedure time, reducing the radiation exposure, and increase the accuracy of the procedure. Interventional hybrid MR is in the horizon, and this will certainly have significant applications both in the aorta and other aspects of interventional radiology. We did some bench work on electromagnetic 3D navigation, and we compared it with fluoroimaging and combined with fluoroimaging and without fluoroimaging, and we found that it is useful on the bench work to combine the 3D navigation with the fluoroscopy in the areas of fenestrated and also in the arch vessels cannulations. It's not available commercially in this area, but it's available in the neuro area and also in the orthopedic. The newcomer to the technology is the robotic endovascular, and we've shown this has a significant advantage both on bench work and also on clinical work in reducing the procedure time, reducing the cannulation time of the vessel, and reducing the number of movement of the wire and catheters, and also reducing the wall hits. This is a software that developed by the engineers at the Imperial, looking at the movement of the catheter tip, and on the left side, the conventional catheter trying to cannulate the fenestration, and the other side is the robotic catheter trying to cannulate the fenestration, both done by the same expert operator. And you can see that the number of movements taken to cannulate the fenestration using the robot are much less, in addition to other features which include the stability along the angulations and also the tortuosities, and the also taking severe curves. In conclusion, fenestrated and branched stent grafts have revolutionized the treatment of aortic aneurysms. Patient selection, however, is crucial for success, and further developments in stent technology and imaging technology are needed to widen the scope of patients benefiting from this procedure. Thanks for your attention.